For those of you who don't know, Teh-wei was born in Shanghai and grew up in Taiwan. His grandparents, who raised him in Taiwan for a decade, had wished for him to go to the United States to study. So nearly 60 years ago, Teh-wei left Taiwan on a 3-day plane ride, which landed him in Oakland on July 1st, 1961. The very next day, I'm told that he came to visit UC Berkeley, which clearly made an impression. But Teh-wei continued eastward, first to graduate school in economics at the University of Chicago. Then he worked at the World Bank and got his PhD at the University of Wisconsin, and then joined the faculty at Penn State. In 1987, Richard Schaeffler and colleagues conspired to finally bring him, his wife Patty, and their 2 sons to move out to Berkeley and join our faculty. In the 30 plus years that he has been with Berkeley Public Health, Teh-wei has made such an enormous impact on our lives and countless others around the world through his research, teaching, and policy advocacy. I was one of those lives that he changed. Teh-wei was one of my all-time favorite professors, not only because he made econometrics fun, or maybe one of the few doctors in the country who actually understood econometrics, but really kind of for his role modeling of the best of what being a teacher, a researcher, and a public health leader and advocate is all about. Teh-wei, you fulfilled your promise to your grandparents, and I'll venture to say that you far exceeded anything that they could have imagined in terms of your accomplishments and your mark in the world. But I'll stop here as I want to introduce a special guest, Chancellor Carol Christ, who really needs no introduction, except that she's truly one of the best leaders I've ever worked with, and that actually included President Obama. And we're so fortunate to have her with us here tonight. So please join me in welcoming Chancellor Christ.
Thank you, Michael. I'm thrilled to be here tonight to see so many familiar faces in the room. The school has been a pioneer in transforming the field of public health and, more importantly, making an impact through its vision, its persistence, its partnership, and imagination and innovation. And Michael, I'm personally so pleased to have you at the helm. I'm also happy to be here at the School of Public Health, which is truly on the front lines of tackling some of the greatest global challenges ahead. That brings me to why we're here. We're here tonight to elevate the conversation about healthcare policy in East Asia, and more importantly, to honor and celebrate Professor Teh-wei Hu. Teh-wei embodies the best of UC Berkeley through his life's work, which has resulted in transforming tobacco use and public health in California and in China, which is no small feat, especially when we remember that China is the largest consumer and producer of cigarettes worldwide, with 350 million smokers in the country. So how did he do it? With vision, with persistence, and with heart. As many of you know, Teh-wei has had a 30-year-long career at Berkeley Public Health, where he began advising policymakers in California about Proposition 99, the Tobacco Tax and Health Protection Act, which instituted a tax, allocated the resulting revenue to smoking prevention, and cut healthcare costs in California by about $86 billion just 15 years later. As a researcher and economist, Teh-wei figured out how much tax would need to be raised to reduce smoking. With his help, California showed that taxing cigarettes resulted in less smoking, which equated to lower incidence of cancer and other effects from smoking and secondhand smoke. But Teh-wei didn't stop there. He brought his research on tobacco taxation to China. He had already spent years educating policymakers there and the press about the importance of a tax on tobacco in terms of lives saved, decreased medical costs, more government revenue, and a healthier environment overall. When he first approached Chinese policymakers about introducing a tobacco tax, he was met with hesitation, if not downright rejection. There are 350 million smokers in China, and the Chinese government owns the companies that make cigarettes, but he didn't quit. In 2015, China finally introduced a tobacco tax, and his work began to pay off. He continued his important work, writing a second book on tobacco policy in China. Today, Teh-wei's research has extended beyond California and China and continues to impact countries as far-flung as Tanzania and Indonesia. Teh has also been given a number of awards, including the Berkeley Citation, the Carl Taub Award for Mental Health Research, and in 2014, the Hu Medal for his impactful work on tax policy in China. His legacy is strong, and today is proof that there is still so much more that Teh-wei has to contribute. One of those contributions is his new 4-book series, Healthcare Policy in East Asia, which we will learn about this evening. But first, I'd like to take this moment to ask Professor Hu to come up, and on behalf of UC Berkeley, we want to honor you with a plaque. So, I gotta get. So I'm going to read the plaque. And thank you. In recognition of Professor Teh-wei Hu's exceptional academic achievement and leadership at the UC Berkeley School of Public Health since 1987, his lifelong dedication to making a meaningful difference in our world, especially his reform of cigarette taxes in China, which will save more than 1 million lives each year, will continue to inspire future generations of Berkeley scholars. So thank you. Congratulations. Thank you. Thank you. Thank you. And now I'd like to introduce Professor Richard Schaeffler, who is going to introduce the panel.
Okay, thank you, Carol. I don't know if I'm going to do any better holding this and juggling these papers than you did. I'm lost already, but I'm going to do one at a time. I think that's what I'm going to do. So before I start, I'd like to say a couple of small things about Teh-wei and myself and my 45-year friendship with him, close friendship. The Chancellor has said many things about his professional work, but can you hear me? Okay, but on a personal level, Teh-wei has been a great friend of mine, to my family and to my children. So I was always curious about what the way was in Teh-wei. What is the way? So I finally Googled it. And I'm not sure if I've got the Mandarin or Cantonese translation correct, but it turns out, not surprisingly, it means great and extraordinary. Great, did I get that right? So his parents, in naming him, had some sense of the child that they would produce. The other thing is just a small personal note. I learned a lot about this volume in walking with Teh-wei over the years. He would test the material on me, country by country. Because we had a walking group that met every Sunday for more than 20 years. There was first Teh-wei and I, and then Joan Bloom, who I see back there, and her husband Howard. And we would walk on Inspiration Point. You guys know where that is. And we would talk health policy, we would talk families. But we'd go out about 2.5 miles, then back. But on the way back, there was this big hill. We get to the bottom of the hill, and I look at Teh-wei. Teh-wei looked at me, and I said, let's just talk. So we would talk and talk and talk. And before we knew it, we were at the top of the hill. That's what a friend is. Someone to walk those hills with you. So, Teh-wei and I have collaborated together, worked together, and traveled together. And no one could have a better friend. So I'm very happy about this occasion and the volume we're about to hear about. Now I'm going to move more to the official program. So our featured speaker is Winnie Yip. Winnie is a professor in the Department of Global Health and Population at the T.H. Chan School of Public Health. But that's not her greatest achievement, because Winnie is a bear. And you'll hear more about why in a moment. She is also the author of the lead volume on China, and an expert and works there continuously, and runs a big program on Chinese healthcare at the Harvard School of Public Health. 2 years ago, she was elected the president of the International Health Economics Association, which is the largest association of health economists that has, I forget how many members now, 4,000 or 5,000 worldwide. Quite an achievement. The last time I saw Winnie actually was in Oxford, when I was spending some time there with my wife. So I fooled you all. How many people think this is a cow tie? Well, you would be wrong, because this is an Oxford tie. So they had the blue and gold, slightly different blue, before we did. Not a big surprise. So I said Winnie was a bear. She is a bear because she graduated from Berkeley, UC Berkeley, with a degree in economics in 1988. And she was a member, not surprising, the Phi Beta Kappa, the National Honor Society. After leaving Berkeley, she went to Cambridge, where she is now, but not to Harvard, but to MIT, and got her PhD in economics. But not too many women were able to do that, I should say. So with great pleasure, I'd like to introduce Winnie Yip, who will be our featured speaker. Thank you, Winnie.
So thank you very much for that kind introduction. I need to say that it's actually my honor to be here to celebrate Professor Hu's professional achievement and all the mentoring that he has done throughout his career. It's not possible for me to call him Teh-wei. I've never been able to call him Teh or Teh-wei. It's always Professor Hu. I don't think I can change anymore. So don't make me change. Now, since Richard was mentioning the word Wei, I actually would comment on the other character of his name, Teh. Actually, it means integrity. And I think it's very much Professor Hu. I think for all his professional life, he expressed and he exercised his integrity to the fullest extent. And to be able to deal with the Chinese government and officials without that integrity, I don't know how you will be able to survive working there for 30-some years. And finally, having an impact on tobacco taxation, which I think is going to affect the life of many, many, many for many years. So I am really honored to be here. I'm very honored to be the editor for the volume on the China volume. So let me just share with you some of the work that we have been doing in China that would track the 20 years of healthcare reform in China. I would say compared to the other three countries in the volume, China's healthcare system in the last 20, 30 years is probably most tumultuous. But at the same time, in terms of the scale and the scope of change and transformation, it's probably also most progressive and also most dynamic. I would call China is actually a wonderful place to study if you are trying to wrestle with that fundamental question of what is the role of the government versus the market in the healthcare system, which I think almost all countries wrestle with, maybe except the United States. And so under communism, under central planning economy, of course, everything in China, including healthcare, is centrally planned. But it was exactly at that time China achieved the most healthcare gain. And in fact, the barefoot doctors at that time was actually the model for the entire primary healthcare movement, including the current Astana Declaration, which is a renewal of the Alma Mater Declaration. But after 20 years of what we call low cost, high, good health outcome, healthcare, China decided that it's going to open its economy and adopt a market strategy. But during that time, they also applied the same principle to healthcare. And I think that was a bad decision for the people, but it was interestingly creating a lot of problems that also has provided a lot of opportunities that have created a new generation of health policy and economics researchers, of which I think Professor Hu played a major role in bringing about. Now, when I first started teaching in China on econometrics for health, people said, have you read Professor Teh-wei's econometrics textbook, monograph in Chinese? I said, I learned econometrics in English. I don't understand any words in Chinese in econometrics. But that was the first textbook that people showed me. And in 2009, China actually underwent a major healthcare reform. And the 10 years before 2009 and from 2009 onward to today, China really encouraged experimentation. It was following Deng Xiaoping's idea that if you don't know the answer, experiment. So his famous saying of crossing the river by feeling the stones. And feeling the stones in healthcare means you do a lot of experiments. And I think that really has opened up a lot of opportunities for researchers to conduct social experiments or to evaluate some of the experiments that the government itself has initiated. And that's much of the content of the volume, of the China volume, is documenting the various experimentations. And in 10 years' time between 2009 and today, and in which China just celebrated its 10th anniversary of health reform, China has decided that you cannot rely on the market to finance or organize healthcare. The government has a significant role to play in healthcare. And in order to do that, the government actually has quadrupled its spending in health. And what are some of the accomplishments? One of the accomplishments is that in a few years' time, China was able to expand health insurance coverage from about 25% of its population to 96% of the population, and has maintained so. And I don't think any other countries in the world have been able to do it in recent history. Utilization has gone up tremendously, and so a lot of the work, evaluation work that is done by the generation, many of whom were trained by Professor Hu, and the next generation is your grandchildren generation, it's not even the next generation, show that the reform has actually improved access to care, has also improved equity in access to care. However, people are still suffering tremendously in terms of financial risk. People still experience bankruptcy in terms of spending on healthcare. And what was the reason? And the reason was because most of its public providers, hospitals or primary healthcare alike, are actually for-profit driven. They are public by ownership, but their behavior is no different from a for-profit entity. And so China also has an interesting policy. They set the fee schedule of which your insurance have to follow. But the fee schedule is such in such a way that if you prescribe a diagnostic test, it has huge amount of profit. Whereas if you sit as a good GP talking to your patient, you lose money. And also, if you prescribe drug, you can charge a 15% of markup. So you don't need an economist to predict that all the hospitals chase to prescribe lots of drugs. And so China probably has one of the highest antibiotic resistance in the world. And the overuse of antibiotics is probably one of the major causes. And all the hospitals, wherever you go, they would have an MRI, they would have a CT. And if you go and say, I have a knee pain, can you give me massage, Chinese medicine? They will still say, why don't you take an MRI first before I give you a massage? I'm sure you have done some of those when you were in China. And so today, China's healthcare system has such serious cost escalation. And this is what I want to show in this diagram. The blue line tracks the real health expenditure growth rate. On an annual basis, it's growing at 12.2%. Now, everybody must have heard about China's economy has grown at a double digit, and that's a miracle. And I often joke and say, well, its healthcare sector also has a miracle, and that is its healthcare expenditure has also been growing double digit. Except that starting from the more recent years, you realize that China's GDP growth rate is slowing down. And in fact, if you look at the president's speech, he called it new normal. That is, the past 20 years of double-digit growth cannot be sustained. China's economy is going to go to a normal rate of growth of just about 6%. So the fundamental question here, I think for the next generation of people doing research in China is, how do you close the gap between the health expenditure growth and the GDP growth? Because government funding is only going to grow at the rate of GDP growth. So what is left as a gap? There are only three solutions. One, you take the health system on a diet, cut fat, which is what the US is trying to do, and many other countries, in fact, in the volume. Second, you have to bring in the private sector. And when you bring in private sector, how do you prevent the private sector is going to create an inequitable system, a two-tier system? That's fundamentally what the Chinese leaders right now is wrestling with. And one reason why China's healthcare expenditure is growing very fast is that I actually think China now has a delivery system quite similar to the US system. That is heavily hospital-centric. If you look at the resource allocation, about 57% of the resources is actually concentrated at big tertiary hospital. Only tiny amount is at primary care, 18%. Meanwhile, China is experiencing aging population, NCDs, and we all know as public health specialists, we want to have a strong primary care system. But right now, it is very difficult to build that because all the big hospitals is having so much power. And when I was writing the volume, Professor Hu said, you have to write the chapter on public hospitals. Because without dealing with the public hospitals, it is actually very hard to make effective use of resources by investing in prevention, health promotion, including not smoking. Because if you go to the doctor, they would give you all kinds of tests. But if you look at the record, do they actually give people smoking cessation advice? No, none of them do that. Because that's not what gives them profit. So what China is right now doing is having a lot of delivery system reform and encouraging a lot of pilot studies. And the delivery system reform, in fact, is very similar to what the US ACO is trying to do. They're trying to do integrated delivery among a set of providers who normally will be competing with each other, in fact. There's no incentive to work with each other. There's no incentive to coordinate. And that's the next phase of reform that China is moving towards. But in order to progress to this reform, last year, there is a major restructuring in the government in order to promote China's healthcare reform. And that is, on the upper side, you see that the different function related to health that is dispersed among many ministries. Of course, these ministries don't talk to each other. These ministries compete for resources. These ministries hate each other. So what the government did is that they combine all the decision that is related to financing, including insurance, including provider payment, pricing of pharmaceutical, pricing of services, into a new agency called the National Health Security Administration. And meanwhile, the Ministry of Health is now solely responsible for delivery system. And I want to put up this graph because of one important thing, that is, before tobacco control is under the Ministry of Industry. And with this reform, tobacco control is now under the Ministry of Health. And I think it's a great signaling that Chinese leaders before, when they think about tobacco policy, it is commercial interest that is more important. But now it is the health interest that is more important. So I won't take more time to go into the detail of China, but I want to take this opportunity to thank people like Professor Hu, who really is the pioneer of health policy research in China and has been a mentor and a role model for many of us, including me. And I have to say that even though I have not worked with you on any single project together, and as junior person, of course, as you do research, quite often someone will tell you that your work is not important. And you feel that this is the end of my career. And I would say quite a few times among those low moments, I would get an email from Professor Hu, not knowing that I'm feeling low. He would say, "You're doing the best work. You need to continue. You are doing the best work. I want you to be editing this volume." And so these kind of encouragement, I think, is critical, essential in building a field, building the next generation. And I hope I can carry on with your spirit and with your encouragement to train the next generation. Thank you.
Well, thank you, Winnie. My next job is to introduce our panel. So many people in the audience have probably heard of the three tenors. Have you? They would be Jose Carreras, Placido Domingo, Luciano Pavarotti. Yes, how many people have heard? Well, we have three deans as our speaker. Michael Liu. Michael, raise your hand. Will Dow, our second dean, current dean, former dean, and our most long-standing dean, Steve Shortell. Left. Our three deans. So you've already heard that Michael was a student of Teh-wei's, and when we were interviewing our finalists, being a graybeard, occasionally walking around the hallway, people would ask me, what did I think? So I asked Teh-wei, I said, "Do you know this guy, Michael?" He said, "Oh yeah, he took my class." I said, "How good was he?" He said, "He was fantastic." So I walked around the 5th and 6th floor whenever he was there. Michael's the guy. If he could do that well in Teh-wei's class and be a doctor on top of that, that was good enough for me. And then Will was lucky because Teh-wei eventually retired, and Will has some big shoes to fill because when Teh retired, we hired Will to teach the econometrics class. And then, luckily for Steve, who was our amazing dean for 11 years, Teh was the associate dean who worked for Steve. So all of these guys have a gratitude and strong connection. So I divided the panel up by country, as you might imagine. I've asked Will to talk about Japan, because he has actually family connections in Japan. Maybe I'll say something about that. And Steve, South Korea, because he's been there numerous times. And Taiwan, because I hope I have this right, that's where Michael is from. So that's our panel. After the panel, each one of them is going to make a short presentation. I'm going to ask one or two questions, and then we're going to turn it over to the audience. So be prepared to ask questions when we're done. So I think I will. Who should I start with? Teh-wei, who do you like? How about Will and Japan? Okay, Will, you're on. So we're going to go.
Great. Well, thank you. As Richard said, I'm really particularly honored to be here because it was Teh's fault that I came to Berkeley, and when he retired, I opened up a spot that I was fortunate enough to be hired into, and I indeed knew that there were very large shoes to fill, and I would never, ever fill them. I remember many years before that, I had a friend who was doing an MPH here at Berkeley, and she happened to tell me, my favorite course, as an economist, she said, my absolute favorite course, and this is an MD who specialized in pediatric emergency room, and she was doing her MPH in epidemiology. She said, my absolute favorite course was cost effectiveness with this guy, Teh-wei Hu. I thought, how about that? And I remember that when I got here, and I was asked to teach econometrics, as Richard said, and also cost effectiveness. And it took me a dozen years before I dared mount a cost effectiveness course, because I knew that I would never be able to live up to that kind of a course. So a few years ago, I was on sabbatical in Japan. My wife is Japanese. I'm not an expert in Japan, so I'll be very brief here. I spent a year in Japan, and it was a fascinating year. And just after that, Teh told me he was writing this volume, and he asked me for recommendations on authors. So I gave him some of the names of my favorite economist academics. And fortunately for you all, the readers, he didn't take any of my recommendations, but he had much better ideas and much better connections. He put together an absolutely stellar list of editors and authors for this volume, folks that had 35 years of experience in and out of academia and government, who were there at the birth of each of the waves of reform in Japan over many decades. And you can tell when you read this volume, it is an amazing volume in terms of the content of what is in there. It was, I think, 2016 when Teh approached me about this. 2019 that is published. That's light speed, as many of you know, by academic publishing standards. But there's nothing light about this volume. It's 23 chapters, over 350 pages, covers every aspect of the Japanese healthcare system that you could imagine. And indeed, it is the definitive English volume, at least, on the Japanese healthcare system that's ever been written. And it is what people are going to turn to for decades to come. It focuses particularly on the last 60 years. Why the last 60 years? Well, 1961, the year that Teh entered the United States, was the year that Japan achieved universal health coverage, what so many countries are still struggling to achieve. So 1961, they achieved that. So Japan, in this volume, is sort of the mature system that we're trying to look to how it did. As Winnie was saying, China is struggling with skyrocketing costs. So we often worry as we move towards universal health coverage, or however the system is structured, we're going to see costs going up and up and up. Well, what happened to Japan? Well, for decades, they were able to keep costs below the level of the healthcare costs as a percent of GDP of all the Western European countries. It was only in the last few years that they hit 10% of GDP on healthcare, which is a lot less than US. As many of you know, we're around 19% now. It didn't break the bank. So how did it do that? It wasn't from a single payer plan. They actually have many, many different private insurance plans. It wasn't because they had public provision of care. It's actually essentially a private healthcare system. Paid fee for service. So what did they do? They regulated prices. They had a very strong government. The government gets together with all of the actors in the system every year, and they update the prices and they regulate the prices. And you see volume increasing. They have some of the highest per capita utilization rates in the world, but they're able to keep the spending in check. And they've been able to do it for decades and decades. And that's a very important lesson for the many other countries that are trying to do this. And so this volume really explores how they were able to do this in wave after wave of reform and ensuring that they were able to keep it this way. What about the quality of care? A system without integrated care. We talk so much about care integration being important for quality of care here. They don't have integrated care. Some people say, well, they don't have great preventive care. Some of their indicators on X, Y, and Z aren't great. They do have the highest life expectancy in the world. And it wasn't always that way. If you go back to 1960, their life expectancy was 41st in the world, so below the US. Not that that's a very high bar, but it was below the US. By 1980, they'd become essentially the country with the highest life expectancy in the world. They're still there except for Hong Kong. It's sort of an exception, another East Asian, a fascinating place to cover. Now they're at 85, their life expectancy. It's US is 79. So they're doing something right. Fascinating questions. How did they do this? What role did the healthcare system versus so many other things have in this? This is the volume that helps you understand what's happened over these decades so that we can better explore these questions. Then looking forward, Japan is the fastest aging country in the world. It's a super aging country. So if you go back to about 25 years ago, about 15% of the country was over age 65. By 2004, they had the highest percent of the population in the world over age 65. Today, over a quarter of the population is over age 65. A lot of challenges that they're going to be facing. A lot of concerns about how they're going to do this. How are they going to do it? Read the book. My time's up.
Well, one of the things I'm going to take credit for is hiring Will Dow. He was one of my hires when I was dean, and a lot of others, as everybody in the room knows, is involved in hiring the superb faculty we have at Berkeley. Some of you are probably wondering, what do I know about East Asia health policy, or South Korea in particular? And you would be correct in wondering about that, because my qualifications are really minimal, but they're not zero, okay? As Richard said, I have been to South Korea. He was very generous, though. I've been there once. Not many times at all. But it was for an entire week. I was, so 7 days, if I can count, 7 times I was there. One day, there's that movie over and over again. But I was there as a visiting professor at Seoul National University. And Joan Bloom, Joan's here somewhere, and there's Joan. I had a doctoral student, my young Sue, a number of years ago, who got her degree here, and she's at the university there, and I was able to see her when I was there, but I did meet with the Minister of Health and some of the higher up people, and also this crazy guy, Dr. Lee, you may recall. Richard and I, for about 12 years, had a Global Health Leadership Forum here at Berkeley, and we had a few South Koreans in that program, so met with Dr. Lee and so on. So I do have some personal experience with South Korea. A few things, though, building on what Will said about Japan, just a few statistics to begin with. And again, there's a whole volume just on South Korea as well, which I encourage you to read because of the similarities as well as differences between Japan and Taiwan and China also, despite some of the geographical, if you will, propinquity of those countries. So in South Korea, they spend about 8% of their GDP on healthcare. And the population, about 51 million or so now. The life expectancy for women there is 79 years. For males, it's 85, so pretty good also. In terms of aging that Will mentioned, by around 2050 in South Korea, 40% of their population is going to be over the age of 65. And they're very ill-equipped to deal with it. The transformative event, in my mind, in South Korea, in their history of their healthcare system, really was around the year 2000, when they went from 237 different health insurance funds to single payer. It's a single payer system, uniform standardized benefits. Okay, so they've got the whole population covered, but it's pretty thin coverage for many people, and 35% of their healthcare expenditures are out of pocket still. So they've gotten a lot of inequity there, and as you look ahead to the aging of the population, I think they're going to have a huge challenge to deal with on that front. Part of their problem is caused by, or at least related to, associated with, very poor primary care system. And to make that concrete, I mean, you saw Winnie's thing there in terms of China and the emphasis on tertiary care hospitals. Many people in South Korea with a common cold, they get it treated in the hospital outpatient department by an internist, okay? You have a headache, as often as not, it gets treated by a neurologist or a neurosurgeon in a hospital department. Gives you some idea, right? So really weak primary care that they're going to have to deal with. On the other hand, maybe one thing they do that we don't have here in the United States is they do have a technology assessment body that looks at new drugs and treatments and so on, and that's worked pretty well for them. And maybe we could learn from that. So I think there's maybe 3 lessons we might draw, and maybe in the Q&A we can get into this a little bit more from South Korea in terms of the U.S. One is the fact that, you know, we all talk about single payer and so forth and so on. There's a lot of different ways to get to universal coverage. As you know, the main reason South Korea made that change wasn't about saving on administrative expense, although they did. It was solidarity. Solidarity was the real motive behind that buy-in. That's not going to happen here. Okay, we're not Canada. We're not South Korea. Okay, it's not going to happen here in the short run, at least, and certainly not for solidarity reasons. I mean, you can see it play out now in the Democratic primary and so on. So there's a lesson there, I think. Second lesson is in the United States, if we have any hope of constraining the rate of growth of costs in our country while maintaining and improving quality and getting at the social determinants, it's going to have to be based on strong primary care. And we're working on that. We are working on that, but a long way still to go. And the third lesson, I think, from South Korea really is around this technology assessment. They have a direct way of negotiating on prices for pharmaceuticals and drugs. And, you know, our government's been unable to do that to date for a variety of reasons. We used to have some years ago a technology assessment body. It was done away with, pros and cons to that. But I think there's some lessons from South Korea. Maybe we could learn about that. So I'll wind up with that, and on our geographic journey here, I think we're going to go to Taiwan. Dean Liu.
All right, well, hard act to follow both as speaker and then as dean. So I'm going to talk about Taiwan, and I'll start with the personal story, which I think some of you have heard. I was born to two immigrant parents from Taiwan who never went to college. In fact, my mom never went to high school or even junior high. See, my mom was only 11 when her father died from an unknown illness, so she had to drop out of 5th grade to go work in the factory. And when I was born, my parents were still pretty poor. My first home was this tiny little apartment on the other side of the tracks in Taipei where a family of 6 was crammed into. No flush toilet, no running water. Unfortunately, I was sick a lot as a child. And back then, there wasn't such thing as national health insurance. And so whenever you get sick, you just never know how much the doctor or the medicine was going to cost. So from time to time, my parents had to make that difficult choice between paying for food and paying for medicine. At one point, my mom sold her wedding ring to pay for my medicine. So fast forward about 50 years, and now Taiwan has arguably one of the best healthcare system in the entire world. What makes it one of the best system? Well, it's got universal coverage for all 23 and a half million citizens and residents on the island. It provides comprehensive services that includes medical, dental, mental health services, most drugs and Chinese medicine, as well as home care. It also provides very easy access. So no gatekeepers, no long lines, and very low cost sharing, such that for most ambulatory visits, the copay is about $2. For most prescription drugs, it's about $7. So you would think that a system that provides universal coverage, comprehensive services, easy access should be pretty costly, right? Well, Taiwan managed to keep its healthcare spending to about 6.4% of its GDP, and that compares favorably with about 9.1% for most OECD countries, and 17.9% for the United States. So how did Taiwan do it? Well, through the national health insurance that established in 1995. And basically, the national health insurance is a single-payer system. And so as a single-payer system, it's got monopsony power in terms of setting rates and benefits and regulating prices to really keep prices low. Okay. It also manages a national risk pool and a single uniform benefit package so that everyone gets the same thing, and that also keeps the administrative costs down. Second, it's also done it through a global budgeting, so that it really caps healthcare spending to the annual revenues that it brings in through premiums and government subsidies and so forth. And so I would say that the one glaring inefficiency within the system is that it maintains a fee-for-service system, which has led to some amount of overprescribing and overutilization as some providers try to game the system, but still that gaming is kind of within the context of global budgeting, and so that's what's still kind of keeping the prices low. And I would say third is just through the state-of-the-art national health information system, so that you have kind of all patient information, all hospital information, all pharmaceutical information, all like stored in the cloud. And so if you show up anywhere with your national health insurance card, any provider would have access to your information. So that national health information system then allowed them to be tracking outliers and overutilizers to be able to monitor fraud and abuse, and in fact to be able to really enable them to do public health surveillance as well, such as infection outbreaks or TB control. So all in all, it's actually a pretty remarkable system. And so amidst the current debate about Medicare for all and single payer system and so forth, I think it's actually pretty worthwhile taking a closer look at the lessons learned from Taiwan's single payer system. So again, just kudos and congratulations, Teh-wei, for putting together this remarkable series of books, but also for all that you did early on in terms of helping Taiwan design and implement its national health insurance. And in fact, in the last week, two of the chief architects of the Taiwan's national health insurance, Tony Chang and Rachel Liu, wrote emails to me and say, please make sure that you thank him in public for everything that Teh-wei has done to help give birth to one of the world's best healthcare systems. Thank you, Teh-wei.
So I want to ask Winnie and the panel to take these seats. I have a long list of questions, but I'm only going to ask one. So be ready, but if you guys are slow, I'll go down my list. So when Teh-wei put together his summary of all the countries, he talked about some of the struggles between a fee-for-service system that encourages more, a capitation system, which sometimes can encourage less, and tried to balance the risk portfolios. He talks about the value of co-payments and controlling utilization, but also is concerned about the ability of the poor to pay them. But at the very end, he comes to a conclusion that I think a lot of people on this panel have, that when you have an aging population, Will made it clear, it's true in all of these countries. Being one of those now in the United States, there's going to be a lot of those joining us. What's the best system we could possibly move to? And I think at the end of the day, Teh-wei says, an integrated delivery system. Thank you. An integrated delivery system. Putting it all together in one place. Steve has written about this his entire life. So if you live long enough.
Up to now. So far.
He's been going for this for, I don't know, 40 years. But in each of these countries, do you see, with this aging population, chronic care delivery system, you think they know that and they'll start to move to an integrated care delivery system? So starting there and then across, and then I'm going to go to the audience. I threw away my list. Okay?
Yes, so as I mentioned earlier, Japan's system does not have an integrated delivery system. It's extremely fragmented. In the volume, they talk about this and the problems that this is going to increasingly cause, especially as we're trying to care for the increasingly aging population in Japan. So they are looking at other models. They're looking to try to create their own model that works for Japan. But there's a lot of ideas there, not clear road for how they're going to get to integration, given that their delivery system currently is so siloed with different systems not talking to each other. Again, it's done pretty darn well to date without being integrated. So I think that there are many things that we need to do. But as they say in the end of the volume, a good system is a system that lasts and that continues to provide, to yield good health outcomes and financial protection. Japan has done that. Could it do even better with integrated care? No doubt. I'm not sure they're going to get there anytime soon, though, as much as they talk about they should.
So for China, the Chinese leaders definitely recognize that integrated delivery system is the next 5 years priority of reform. So in fact, every document that you read is about integrated delivery, except that China doesn't have primary care. So all the integrated delivery system is led by hospital. So what the hospitals want to do, hospitals basically use all these outpatient clinic as their way to attract more people to come to their hospitals. And I think that the objective is very clear, but how do you make it happen? It's not going to be as easy. I think that in that sense, China has a very similar system as the US. It's very hospital-centric. It's also very specialist-centric. In fact, China has a new policy strategy called Healthy China 2030. And one of its priorities to say that by 2030, China's healthcare system should be switching from focusing on patient to focusing on people. From focusing on disease to focusing on keeping people healthy. So the direction is very clear. And I think the difficulty is how, when you start with a very weak base.
Picking up from that, South Korea is not that much different in that regard. I should have mentioned earlier that they are also fee-for-service. So they're 8-9% of GDP now, and with this aging boom, it's just going to mushroom further. Very weak primary care base, just as in China as well. One distinction, very important for us to be on a common knowledge base here about integrated systems. One way to think about that is the financial integration, where there's ownership and consolidation of the hospitals and the primary care sites and so on. And it's not so much that we talk about around integrated care models. It really is what's called clinical integration, namely where you touch the patient and their needs in the community. It's the degree to which care is coordinated, fragmented, the patient doesn't get lost. You don't have to repeat tests and exams and so on. So that's what we're really talking about. Whether or not financial integration or economic integration of the care components promotes clinical integration or not is an empirical question. Some of us are studying that, and a lot of people are studying that. So I think the key for South Korea and these other countries we're talking about indeed is going to be, as all of us have pointed out, with aging population, is chronicity. It's chronic illness. You're seeing so many more providers. A lot of that has to be your own self-management of your care. If you have diabetes, heart disease, and so forth, assisted by the care team, which may well include community health workers out there in the community. And that's the kind of challenge these countries face. The difference, I think, from 10, 15, 20 years ago is really the access in terms of social media and how quickly information now spreads. OECD, countries, etc., the European Observatory, which now more East Asia is getting involved with that as well, around these new care models and how quickly you can learn. And in my mind, it's really going to be constrained by the political systems in these countries. The knowledge is there, and even the knowledge of how to implement, not just what to do, but how to do it is there. But whether or not the politics are going to be there to allow some of this progress to be made remains to be seen.
Yeah, I think similar discussion and deliberation is taking place in Taiwan in terms of thinking of system reform, system transformation toward a more integrated system. Currently the long-term care is not covered, but as the population continue to age, there's been a lot of talk about providing coverage for long-term care, but not just coverage, but let's make sure that we provide coverage for integrated long-term care. But what exactly would that look like is a subject of very intense ongoing discussion.
Well, thank you. Just a throwaway line before I ask the audience for questions. Steve and I are actually writing a plan for PAHO, Pan American Health Organization, on integrating care in Peru. We're almost done with it. The Peruvians have gotten a $400 million loan from the World Bank, and our report is focused on how they should do it and how they should spend the money. So we're trying to actually move this in other parts of the world.
Can't raise our rates, though. That's a joke.
That was my charity rate, by the way, for that report. Anyhow. So I want to turn it over to the audience for questions. And so I'm the only one with a microphone, so I'm going to be one of these people who hand you the microphone. I see
We got
fit.
mics. Oh, yeah. We
No.
can get.
Unless someone else wants to do this.
Thank you so very much. I applaud all of you on your comments. Two quick questions, but the answers are longer. One is, how do you break down the silos that exist? And the silos are all over the map between social interest, social work, public health, clinical issues. All I heard you is talking about what I've heard all my life is the illness model. I haven't heard much on the health model. And two, coming back to where you're all living now, my passion is in rural America, which is a total disaster. So everything you said about overseas is not being addressed to the 57 million people who are in rural America today. So how do you break the silos? Because of all these academic institutions I've had affiliation. There's a school of public health. There's a school of medicine. There's a school of behavioral health. There's a school of this. And if you go back, and I'll leave this with the definition the World Health Organization put forth in 1948 for health. Health is a state of complete physical, emotional, and social well-being, not merely the absence of illness or infirmity. We've made very little progress there, and we haven't done well on the choosing wisely thing on how do you get people to use experience-based knowledge in the practice of medicine.
We'll take two answers. Who wants to take that one?
Well, I'll start. Phil is always very direct in your questions. So whether it's, rural America here and we're as worse off as maybe some of the challenges of East Asian countries have or developing countries indeed, for sure, the inequalities and so on. So just a couple of thoughts. If we had solutions, we wouldn't be here talking about them. They've been around for decades. So one of the things I think is common incentives, pooling of funds. So if you talk about how do we involve the social determinants and so on, one way is to have a pooled budget of the healthcare and the social services, housing, transportation, and so forth. That's pooled funding from the beginning, okay? If you can't do that, then what some countries are doing, Spain, for example, examples from Catalonia, braided funding in the Basque Country. So they don't from the beginning pool the funds, but they have the health budget, they have social services budget, and then as they identify the needs of the population, they have electronic health records, which help them a lot. They braid the funding. In other words, they transfer from one to the other in order to meet the patient's needs and family needs. At the end of the year, they have a way of settling up, so to speak, but they don't do it at the beginning. That's what they're aiming for, but they're not quite there yet. So, I tend to look at the pros and cons of how we pay providers in this country, and I come down on the side of global budgets to keep people well. Argue about what they should be, argue about how you're going to risk adjust. Kaiser's been doing it for 6-7 decades now. You have real incentives to keep people well. Rural America, I would look for enhanced partnerships on steroids, where the nearest academic health center or reasonably sized hospital, you create incentives for them to adopt whatever it is, the rural community. And with telehealth technologies now and digital and so forth, make use of those. I'm looking for innovative models of some of that, and you and your work can actually encourage some of that. There are a few examples around. We don't have enough. So I don't know, that'd be a starting point to the conversation.
I just add that pooling the resources and the incentive is critical, and in fact, a number of pilot sites in China is moving towards that. So they're moving away from fee-for-service to when the insurance, the social insurance of that particular region is paying for an integrated delivery system, they actually pay a bundled payment, a global budget. And so everybody in that integrated delivery system, somehow, if they lose, everybody would have to share that lose. And if there is savings, they would be able to benefit. So that's one. The other thing that is happening in China, which you mentioned, but I think China might be even doing faster than the US is, I do think that internet-based and technology is going to be a game changer. because what is happening in China is that even in many remote places with internet, most people would have a cell phone. And I just went to one of the poorest county in China, and all the information system, public health, hospital, medical record, insurance claims data, they're all integrated in one system. And even if you're a farmer, you have on your phone your own record. Any encounter that has happened, it is sent to your phone. And I think the next phase is helping, I won't call primary care doctor, I would say minimally trained community health worker to be able to use some of those very simple technology to actually track people's behavior and changes when they're at home. So it's not about training more doctors. I don't believe in training more GPs in China, because once you give them a degree, they want to go to the big city. You can't really keep them, and you don't need them. You need people who are trained really well to do a few things very well, but their heart have to be part of the community. I think that is the hard part, to have them feel that they are there for the people rather than to become a specialist.
Next question. Raise your hand. The microphone will. Kurt.
Thank you.
You're on.
I'm on?
Yes, you are.
Oh, okay.
My friends always come first.
Oh, thank you. Okay, thank you. I wasn't going to say anything about this until Steve admitted that he'd been in South Korea for a total of a month. I mean, a week. And I just,
like the elaboration.
right. No, by coincidence, I was just in Singapore, I guess, the same time you were, Michael, for 2 weeks working with the Ministry of Healthcare Transformation. And Teh's huge mentee and a follower of many of yours, Mei Wang, who's, a professor in UCLA now, is in Singapore and invited me to help them in their work. The thing that struck me, though, and that is, I think, in contrast to everything we've heard about these countries, is in Singapore, when they became independent in 1965, the first thing they did for health and everything else was address in their country, ethnic tensions and wealth disparities through housing. And they were particularly convinced back then that housing would be the way to deal with health. So long story short, you have these huge, towering, very nice looking apartment buildings. Everybody's there from the very beginning. They tried to integrate by race, ethnicity, and by income. They have polyclinics at every single estate, as they're called. Some of the wealthy people stay there and have elaborate additions. The poorest of the poor are there and have tremendous subsidies, so they basically pay almost nothing. But there are polyclinics in every one of those sites. There are exercise, elaborate systems for kids, for middle-aged people, for elders, and people with disabilities. The whole system, and I went prepared not to like this too much because I knew it was very top-down in many ways, but I was blown away. What they are trying and what they've accomplished is pretty amazing, and I think it's partly because they pay attention to social determinants and make housing at least as much of an issue as health.
Well, thank you. That's Mary Minkler. In case you don't know, I should have asked people to introduce themselves. So when I came to Berkeley 40 years ago with a PhD in economics, I didn't know much about public health, and I learned most of it from listening to Mary Minkler. You can see why. So do we want to have any comments, or just take that and face as some advice? Does anybody want to say anything?
I'll say, yeah. So, and also kind of pertinent to the last question. Certainly, we know healthcare is what 15, 20% of health. Everything else depends on the air we breathe, the water we drink, the food we eat, the social conditions in which we live. And so two thoughts about this. One is, how do we transform the healthcare system so that it's better equipped to address these social determinants of health? And then secondly, when you have federal health spending, federal spending on public health being 3% of our overall spending on health, there's a disconnect between what we spend on public health and how we're going to truly move the needle in population health.
So I'm afraid we have time for one more question, and then I'm going to let, yes.
So I have a question. We used to talk about the East Asian tigers. I didn't hear that.
Would you
expression,
introduce yourself, sir?
My name's Kirk Smith. I'm a professor
Yes, you are.
here. And the East Asian, I'll leave China out of it for the moment. The East Asian tigers, that's what you're talking about here. And there have been a lot of changes that have occurred in East Asian tigers. I mean, they were at war with each other up until 1950 or afterwards. And remarkable changes, improvements of the economy, improvements in the amount of democracy, and the way they reflect what their public is doing, the success of their governments. I was involved in a study looking at completely different things. It was the evolution of the power systems, the electric power systems in those countries. And they got together and they decided on what to do. So my question, and also environmental regulations, starting with Japan at the top, but, kind of folding down into the other two East Asian tigers afterwards. So my question is, was there a conscious effort among the governments, the three Asian tigers, to actually work together to understand these problems and to accomplish things together? Or is this all, done internally?
I'm going to give Will the first shot.
I'll let other people contribute to the history as well. But, Japan did this first. It wasn't in collaboration with the other three countries that are represented here. It certainly was learning from some of the European systems as they did this. But your comment about the Asian tigers, as an economist, people often talk about the miracle of the economic growth in the Asian tigers, that economic growth was very fast over this period. And certainly that was one factor that contributed to allowing these countries to invest in these types of services that are improving health and moving towards universal health care. Although I wouldn't say that is a necessary condition, because we see other countries like Costa Rica, where I've studied, that didn't have anywhere near that kind of economic growth, and they decided to invest in these services, create universal health coverage, and has excellent health outcomes as well. But I think that the other component, beyond just the fact that their economies were growing fast, they had very strong and very capable governments, right, that were able to make decisions and execute. And fortunately, they made many good decisions along the way in terms of investing in human capital and healthcare systems.
Just to underscore what Will has said, Kirk, the same story for South Korea. When around the year 2000, they were able to make this great transition, universal coverage, it was because of their economic growth. Absolutely. The other thing that was going on a little bit in South Korea is the presence of North Korea. Okay. And that was also involved. And then the strong government, but also the high emphasis on human capital in South Korea, education. They're landlocked. They don't have a lot of natural assets, but boy, do they believe in an educated populace and access to education. And you see it, you feel it when it's down there. It can have a negative side because there's a lot of pressure, for the kids to succeed and all of that. They're on a lot of stress. But those have all been factors why South Korea has been able to make this transition to universal coverage, but with some of the problems and challenges that I mentioned as well.
So you guys stay up here, but I want the audience to thank Winnie and the three deans. Stay there. Now I'm going to give the microphone to Teh-wei, who's going to make some concluding comments.
Thank you very much. First of all, I'd like to thank Dean Michael and his dean's office staff, Priya, and Sophia and others for making this event possible. Of course, I want to thank my dear friend, longtime friend, Richard, who spent so much of effort and time to do this. And furthermore, obviously, I want to thank panelists, my dear friend, but also Winnie, flying from Boston today and under the busy schedule. And I'm so delighted that she can join us. About the book, I want to thank also Richard and Winnie. Like Richard mentioned, that we walk together 25 years every Sunday if we are in town. And well, then of course Joan and Howard joined us the last 10 years. So this book, it was the publisher offered me when they realized that I have done some work on healthcare reform in Asia, particularly Taiwan and China, and some acknowledgement but know about South Korea. So they said, want me to do it. I was not sure to do it because it's so demanding to do that. Because so therefore, when I walked with Richard, first thing I asked him that, should I do it? It's a lot of work. And Richard said, why not? It's an important topic. And he gave me inspiration because he did the handbook, economic handbook, so quickly and succeeded. So I said, well, that's easy, but that's enough. So the second person I did was I called Winnie, sent an email to her. I want to know whether she is willing to be an editor. If she said yes, then I'll go for the Taiwan and Korea and Japan. I was lucky. She said yes, she wanted to do it. I was so happy. So because of you too, I follow up with the message to Dong Liang, Zhang, and also Dong Ming and my Japanese colleagues. So I'm going to make some quick, this time is running late. I want to make a quick remark about what about this book? You know, we learned all these, the 4 countries, and when I was editing, I developed some framework, but also I want to encourage the editor to talk about how we can learn from each other. And but also this is in reference to about how about the United States? We heard about the Medicare for all, right? So essentially, the WHO wanted to have this goal called the universal health care coverage. What does that mean? Is that we want to have access, easy access, affordable access, efficient access, and then also low cost, and people are happy with the outcome. So with these goals, can a system to achieve all 3? Not one system can achieve all 3, because these 3 goals are competing against each other. Either you have spent too much money you worry about, or you don't have the access, or people are not happy. So from this book, you can tell there's no perfect system. The healthcare reform is always dynamic. And the question is how we can deliver this, the system that we like to have a balance. So what we have learned from all this, number one, we need money. We need the financial resources. The question is how we can collect it, in what way we can collect, how we can, each country, sometimes from a taxation or some insurance plan, but how we can become an efficient collector, such as single payer. So like a single payer, well, Taiwan has succeeded. Now, in terms of money, like I have said, economic growth really led to a lot of money. China putting about $900 billion in the last 10 years just for healthcare. But look, your problem. We still have a problem, right? People have problem of paying on their own, or the access and the problem. Now, in terms of Korea, actually, they envy about the Taiwan system. The designer said, we wish we will have a global budget like Taiwan did, instead of a fee-for-service and have everybody to just on their own. However, Korean has a lesson for us to do. That is how to integrate insurance. How you can integrate insurance from 300 local insurance company, government company actually, become one single one. So we can think about all this issue here. And then obviously the number 3 is the role of government. If we really want to succeed, like the United States, It's not the administrative government. It's not White House. Not only White House, but also the legislative. So you have to have both parties together if you have strong will. If you don't have strong will, you won't be able to succeed. Now, with all that we talk about, I want to go back to what Steve and the other specialty on the organization and delivery. So when we talk about all these issues, how we can design a delivery system, an organization system that make it work. My last word is incentive. That is the key word from economics point of view. You have designed incentive that will make sure that the consumers will not waste the resources, will not overuse it, but also you want to develop incentive for the providers to pay for service, but also pay for performance. So therefore, it's a challenge for us in the field of health economics or healthcare delivery researchers. How you can design the financing, organization, and delivery together. And that's where they come in for the Medicare for All also. I hope that some of the candidates can think about ways to do it. So I want to thank you very much for all the, obviously I want to thank many of you coming such a late day, and also coming from New York, from Boston, and from LA, from Davis, and other places. So I really, and see a lot of good friends, old friends. I really appreciate that you have given me a chance to reunite and to see you. Thank you very much.
Well, we're done with the final program, but we have one more thing to do. So, Teh-wei, would you come here? So 2 weeks ago, over here, the whole group. You in the middle, young man. In the middle. The middle is the mean, the median. One of those, the middle. So several weeks ago, we had a small lunch for Teh's close friends on the faculty. So we can all fit around one table at the East Asia restaurant in Emeryville. Good dim sum, was quite good.
The dean popped for it.
And the dean, it was right, and the dean paid for it, so it was fee for it. We ordered a lot. We know what moral hazard is. We took home bundles of food. Also with us was Joan Bloom and John Schwartzberg, who has worked with Teh on the wellness letter. So we thought that we would commemorate the lunch. And Michael was our dean. He's quite an amazing character. Was clever enough to take some very good photographs of our lunch. So what we have in there, you can open if you want. It's a framed picture of our lunch at the East Asia restaurant 2 weeks ago with Teh-wei. And we had a bonus that Joan's husband, Howard, was also able to attend. So all of us were there, and it is now a gift to you. You can open it up. I don't think people can see it from here, but we'll. Boy, you really wrapped it there. What did you do? What is this here? Okay, let's open it. Another wrapping. Oh, it's a good picture. It's really a good one. Okay. I'm going to take the paper. You want to hold it up there? And so that's our gift to you of our Berkeley lunch with a little Berkeley citation. So I'd like everybody to stand up and let's have some final applause for Professor Teh-wei Hu.